Good evening. I happened to watch an online debate on gold standard in discectomy. Let us explore the truth. Meaning of gold standard, something that is very good and is used for measuring how good other similar things are. So it need not be a popular technique done by many. In the past, microdiscectomy was the gold standard and today it is full endoscopic discectomy. Coming to skin incision, the proponents of Destando technique claimed that skin incision does not matter. This is because they make big incisions. This is the language of open surgeons. When you talk about minimally invasive surgery, skin incision is one of the most important factors when the outcomes are same. We know that smaller incision is associated with less trauma, less muscle damage, less bleeding, less pain, faster recovery, and less complications. Even a primary school child will tell you that 8 millimeter is not equal to 18 millimeters. In full endoscopic discectomy, we use a skin incision of 7 to 9 millimeters depending on the system you are using. This is unmatched by any other technique, whether it is Destando or tubular system. Today's surgery is about the art of handling tissues with delicate instruments than use of big, bulky, old instruments, which is a thing of the past. And instrument breakage is rare in the hands of an experienced endoscopic spine surgeon. Wake up, guys, this is 21st century, not 1934. Coming to anesthesia, because Destando technique is more invasive, it requires more depth of anesthesia like general anesthesia, whereas full endoscopic surgery can be done under local anesthesia or a regional anesthesia. We know that general anesthesia is not equal to local anesthesia. If the patient has a bad lung condition, then giving general anesthesia is very risky. So full endoscopic surgery has advantage over other techniques. Coming to cost of instruments, cost should not be an excuse for not learning endoscopy. When we can afford Chandrayaan or Rafale jets, we can afford full endoscopic systems. We have started Make in India program for full endoscopic instruments since 2012. This has contributed to the popularity of full endoscopic spine surgery, at least in India. Today, you can get a full endoscopic system for under 5 lakh rupees from Haber Surgical Instruments, Chennai. Coming to the endoscope, Destando uses a 4 millimeter endoscope using a big sleeve, the diameter of which is not mentioned. Because the sleeve is conical in shape, if you have a obese patient with more depth, you have to make bigger and bigger incision. Whereas in full endoscopic surgery, we use a 4.3 mm working channel, 6.9 mm outer diameter of the scope, and cannula with outer diameter of 8 millimeters. And the obesity or weight of the patient does not determine the size of skin incision. Even in a patient of 140 kg, we can manage with the 8 millimeter cannula. Coming to endoscope mobility, it is common sense that small sleeve or a small size cannula gives more mobility, which has additional advantages of less soft tissue trauma, less bone resection, less bleeding, less pain, and faster recovery. Coming to exposure at the site of pathology, full endoscopic surgery gives the best exposure. This is because of 15 to 30 degree angle the scope has, and the scope is at the tip, and 360-degree rotation of sleeve and scope is possible with full endoscopic technique. If you see the Destando system, you cannot rotate the sleeve. This is a big drawback, and the sleeve is so bulky that mobility is limited unless you do more dissection and more bone cutting. This picture gives the exact exposure given by each technique, and we can see that because 360-degree rotation is possible with both the cannula and the scope, full endoscopic technique gives the best exposure at the site of pathology. In addition to 360-degree rotation, the use of saline irrigation improves the space and the vision. It controls the bleeding and it protects the dura and the roots. And all this is possible with 8 mm cannula. And the same system is used for cervical, thoracic and lumbar, whether it is transforaminal approach or interlaminar approach. Same cannula, same system is used. Coming to wet or dry technique, even laparoscopy uses carbon dioxide under pressure for distension and visualization, which is not there with the Destando technique. And advantages of saline irrigation have been already mentioned, and if somebody does not understand this, I think we should not debate or argue with them. We should just leave alone. Coming to dural tears, the literature gives enough evidence that dural tears are extremely rare with full endoscopy, and even if there is a tear, because of the small size incision, no dead space, it can be left alone and there is no need to open for dural repair. Other issue raised was fluid overload, and there is no issue of fluid overload when we use gravity method in an awake patient. Coming to true or false endoscopy, definitely Destando is not a true endoscopy because of the factors which we have already mentioned. It is an old endoscopic technique, whereas full endoscopy is the true endoscopic technique. Coming to versatility of technique, full endoscopic procedures are as versatile or even more versatile than any other existing technique. For example, if you take a discitis, it is not possible to do debridement in a discitis without violating the spinal canal using Destando or tubular systems. Only transforaminal technique allow you to do debridement without violating the spinal canal. These are some articles just to support the evidence for full endoscopic surgery. There are enough evidence to support full endoscopic spine surgery. Coming to learning curve for full endoscopic spine surgery is definitely shorter today. Patience, perseverance, persistence and passion is required if you want to master full endoscopic spine surgery. A dream does not become reality through magic. It requires sweat, determination and hard work. This is the least invasive fusion done using full endoscopic technique with just 2 10 mm incision. This is not possible with Destando or tubular systems. Conclusion: truth cannot be hidden in the web of lies. For full endoscopic system, we don't require 15 or 16 mm cannula. Please check the facts before you come for debate in a scientific meeting, and do not defend the indefensibles. Just check how many of the youngsters want to learn your technique or buy your systems. When facts are there, we don't require philosophical arguments. We need scientific evidence. Writing is on the wall. If you do not agree, wait for another 10 years. And intellectual stubbornness is of no use. I have nothing against people doing microdiscectomy or tubular discectomy or Destendo technique or even open laminectomy. Do whatever works best in your hands, but don't come for debate on gold standard unless you are able to work with a 7 millimeter or 8 millimeter cannula. So it is up to you if you want to see the light or remain stubborn. Thank you.